on this presentation today. We have Joanne Kagema. She's an especially nurse and technologist at KNH and has done a lot of work around oxygen and oxygen devices, which is, I think the last time I met her, she was very passionate about this topic. So I was told her she has to come and teach us about this. So without much further ado, Joanne, feel free to kick off the presentation.
Thank you, Dr. Wachira. I appreciate. We are going to discuss about matters of oxygen because it's one of the drugs that we use often where we have issues on breathlessness and dyspnea and shortness of breath. But how do you use it and to whom do we give it to? So some of those questions that we may come to ask ourselves, and then we try to think what else can you do better. My objectives is definitions, purpose, patients, factors, oxyhemoglobin dissociation curve, markers of oxygen monitoring, clinical manifestations, goals of oxygen delivery, indication for oxygen therapy, normal values, oxygen delivery methods, when to stop oxygen, and the conclusion. Oxygen therapy is the administration of oxygen at concentrations greater than that in room air to treat or prevent hypoxia. We need to look at definitions and terms that we use in oxygen. One is fractional of inspired oxygen, which we do it in percentage. The other one is partial pressure of carbon dioxide in arterial blood. It is used to assess the adequacy of ventilation. The partial pressure of, the first one was partial pressure of carbon dioxide in arterial blood to assess the adequacy of ventilation. The second one is partial pressure of oxygen in arterial blood. It is used to assess the adequacy of oxygenation. The SA02, that is the saturation of oxygen, is the arterial oxygen saturation measured from blood specimen, where we do arterial blood gases. We have also SpO2, where the arterial oxygen saturation is measured via a pulse oximetry. The purpose is when the body is constantly taking in oxygen and releasing CO2. If this process is inadequate, oxygen levels in the blood decrease and the patient may need supplemental oxygen. The purpose is to increase oxygen saturation in tissues where the saturation levels are too low due to illness or injury. When we look at patient factors, we look at severity and the cause of hypoxemia, patient age group, maybe infant, child, or adult, degree of consciousness and alertness, presence or absence of tracheal airway, stability of minute ventilation, and mouth breathing versus nose breathing patient. We look at the oxyhemoglobin dissociation curve. When you look at definition, it's a relationship between the amount of oxygen dissolved in the blood and the amount attached to the hemoglobin. Oxygen can be measured in two forms, can be through partial atmospheric pressure of oxygen, which is PA and O2, oxygen saturation, which is SaO2, and calculated estimate of oxygen saturation due by SpO2 or an indirect saturation, oxygen saturation. That is the normal oxyhemoglobin dissociate curve. We have the predicted relationship between the partial oxygen and also pressures and also the saturation of oxygen. The normal hemoglobin dissociation curves, when you talk about the hydrogen pressure of associated of oxygen, the pressures, when we talk of saturation, it goes to 98%. As we go down, also our saturation of oxygen in percentage decreases. So when you come down below the normal oxyhemoglobin dissociate curve, when the saturation is at 97, the pressure of oxygen, it's at 97 and it's normal. The pressures, it's at normal. When it goes to 90%, then the oxygen pressures, there is 60. There is a bit of the danger. When you go to 80% saturation, we are talking of 45 of the oxygen pressures, where we can be having a severe hypoxia. We come to arterial blood gases. What we look in arterial blood gases, we look at the pH, we look at the carbon dioxide in pressures, and we also look at oxygen in pressures, and also we look at hydrocarbon dioxide in pressures, and also in oxygen saturation. And also in arterial blood, those are the values that you can get, and in the venous. So sometimes when we are removing the oxygen, the arterial blood gases, you may get that we have removed from the venous, and there is always a difference when you're having the venous blood. But when you get a collect arterial blood gases, we at least get the light values when we are measuring the saturations of the oxygen. We go to the markers of oxygen monitoring, the pressure inspired oxygen at 76. These are some of the mathematics that can be done, and actually we can get it at 150 millimeter of mercury. We have fractional inspired oxygen, which is equal to 0.21. Partial oxygen pressures at 100 millimeters of mercury. And we have also the 90 millimeters of mercury. We have the saturation, which is derived from arterialization, that one that comes from the capillary blood, and also we have the SpO2, the saturation by the pulse oximetry. When we talk about the assessment of need of oxygen, of oxygenation, where there is need is determined by the measurement of inadequate oxygen tensions and or saturations by invasive or non-invasive methods, and or the presence of clinical indicators as previously described. That ones, when we need to assess the oxygen values, we may do it through the arterial blood gases. We may assess it through the pulse oximetry, or maybe through clinical presentation, where the patient comes with the shortness of breath. Sometimes when we are doing a pulse oximetry, we need to look at what the errors can be there in pulse oximetry. One is the artificial fingernails. Sometimes when you have a patient who have artificial fingernails, sometimes where we have drug pigmentation, electrical, intravenous dyes, movement, nerve porridge, pulsative venous system, radiated right, edema, and sometimes when you have the code extremities, sometimes you may not have the right reading of pulse oximetry. The clinical manifestation, as we look about the systems, when you look at the whole system, when you look at respiratory, most of the signs that we get is tachypnea, dyspnea, and cyanosis. In the cardiovascular system, we get palpitations, we get increased CO, carbon dioxide, tachycardia, arrhythmias. You may get even hypotension, angina, diaphoresis, and even choke. When you look at CNS, you may have the headache, confusion, and euphoria. You may be delirium. You may be having papilledema, seizures, agitation, and coma. When you have metabolic, you may having lactic acidosis or sodium acidosis and water retention. Or when we have neuromuscular, you may have weakness, tremors, and coordination and hyperreflexia, or even ataxia. What are the indications of oxygen therapy? One, a look at acute oxygen therapy, where we have acute hypoxemia, where the pressure atmospheric of oxygen is less than 60 millimeters of mercury, where the SpO2 is less than 90%. When you look at cardiac and respiratory arrest, hypotension, where the blood pressure is less than 100 millimeters of mercury, low cardiac output plus metabolic acidosis, where it could be less than 18 millimeters of mercury per liter, and even respiratory distress, where we have respiratory rate of more than 24 beats per minute. When we have long-term oxygen therapy, where it can have continuous oxygen, we may be talking about resting atmospheric pressure of oxygen of less than 55 millimeters of mercury, or SpO2 of less than 88%, or resting of pressures of 56 to 59 millimeters of mercury, where is SpO2 of 89%. This is of 89% in the presence of carpopulmonary or dependent edema or cardiac heart failure, carpopulmonary on ECG, or polycythemia with a hematocrit of more than 56%. When you talk of non-continuous oxygen, which actually nowadays we don't recommend it, is during exercise. So the goals of oxygen delivery is to maintain targeted SpO2 levels in children, do the provision of supplemental oxygen in a safe and effective way, which is tolerated by infants and children. Relief of hypoxia and maintain adequate oxygenation of tissues and vital organs as assessed by SpO2 or monitoring of oxygen and clinical signs, either by arterial blood gases. Give oxygen therapy in a way which prevents excessive CO2 accumulation, that is selection of appropriate flow rate and delivery device. Reduce the work of breathing, ensure adequate clearance of secretions and limit the adverse events of hypothermia and insensible water loss by use of optimal humidification that is dependent on mode of oxygen delivery. It will depend on which mode of delivery, oxygen delivery you are doing. Maintain efficient, economical use of oxygen. Those are the main goals for oxygen delivery. So when you talk to normal values of SpO2 targets, partial pressure of arterial oxygen should be between 80 to 100 millimeters of mercury, either in children and adults, 50 to 80 millimeters of mercury in neonates, partial pressure of arterial CO2 between 35 to 45 millimeters of mercury in children and adults, pH between 7.35 to 7.75. Generally, the SpO2 targets are between 94% to 98%, with a partial pressure of 80 to 100 millimeters of mercury in patients without cyanotic congenital heart disease or chronic lung disease. More than 70% of partial pressure of that 7 millimeters of mercury in patients who have had cardiac surgery of the congenital cyanotic heart disease, they need oxygen. More than 60% is unimpaired congenital cyanotic heart disease. Between 91 and 95 for premature or term neonates. More than or equal to 90% for infants with bronchiolitis. The above values are generalized to the pediatric population for age and patient and specific ranges, but also it can also occur for adults. The above values are expected target ranges. Any deviation should be documented on the observation chart. It can also occur even for the adults. Techniques of oxygen administration. Oxygen delivery system is a device which is used to administer, regulate, and supplement oxygen to a subject to increase the arterial oxygenation. Choice of delivery system. The choice of delivery of oxygen is based upon the following: degree of hypoxia, requirement of precision of delivery, patient comfort, and the cost. Oxygen devices, we have nasal cannula or plungs or crowns, nasal catheters, transtracheal catheter, face mask, partially breathing mask, non-breathing mask, and tracheostomy mask. Nasal cannula consists of two soft plungs attached to oxygen supply tubing. The flow is of between 2 to 4 liters per minute and delivers a fractional inspired oxygen of 0.28 to 0.36 respectively, or in percentage. The fractional inspired oxygen, there is no increase in fractional inspired oxygen if flow is more than 6 liters per minute. Nasopharynx acts as reservoir. If patient breathes through the mouth, airflow produces a venturi effect in the posterior pharynx and training oxygen from the nose, available in different sizes and different plung shapes. That is the nasocannula, nasoprone. The advantages ideal for patients on long-term oxygen therapy. It's lightweight and comfortable. The patient is able to speak, eat, and drink. Humidification not required, and it's low cost. Disadvantages can not provide high flow oxygen. There is irritation and can not be used in nasal obstruction. Fractional inspired oxygen varies with the respiratory efforts. High flow rates are uncomfortable. When you come to nasal catheter, single lumen catheter, which is lodged into an anterior nares by a foam collar inserted to just above the uvula. Oxygen flows of 2 to 3 liters per minute can be used with fraction inspired between 35 to 40%. It should not be used when a nasal mucosal tear is suspected because of the risk of surgical emphysema. Deep insertion can cause air swallowing and gastric distension. Must be repositioned every 8 hours to prevent breakdown. No advantages of a nasal cannula. That one is mostly we do it in the small units. When you come to the nasal catheter, that is one of them. So we come to simple face mask. It's a transparent mask provided with side hose. It's a capacity of 100 to 250 mils. Different oxygen flow rates result into a high variable and unpredictable fraction-inspired oxygen. The breathing of CO2 can occur with oxygen flow rates of less than 2 liters per minute, or if minute ventilation is very high. 4 liters per minute of oxygen flow delivers a fraction-inspired oxygen of about 35 to 40%, provided there is normal respiration pattern. Flow rates greater than 8 liters do not increase fraction-inspired oxygen. We come to a simple mask. Advantage is less expensive and can be used by in-mouth breathers. Disadvantage is uncomfortable, require tight seal, do not deliver high inspired oxygen. Fraction inspired oxygen varies with breathing efforts, interfere with eating, drinking, and communication. Is difficult to keep in possession for long. Chances of rebreathing are high. That is our mask. When we come to partially breathing mask, it has a reservoir of capacity of 1 liter. Oxygen flows directly into the reservoir bag, which fills directly and fills during the acceleration, designed in such a way that it captures exhaled gases from initial part of its expiration from the dead spaces, useful in situations where supplies are limited. That is the partially breathing mask. When it comes to partially breathing mask, it delivers fraction inspired oxygen between 60 to 80%. A minimum of 8 liters per minute should enter the mask to remove exhaled CO2 and to refill oxygen reservoir. Flow rate must be sufficient to keep bag at a third to a half inflated at all times. The advantage is inspired gas does not mix with room air. Patient can breathe room air through exhaled parts of oxygen supply if oxygen supply gets interrupted. Disadvantage, there's more oxygen flow. More oxygen flow does not increase fractional inspired oxygen, interferes with eating and drinking. Non-breathing mask, which we have, which is in most hospitals and which we have, provided with one-way valves between mask and the bag, exhalation ports. The fractional inspired oxygen is of 95% and can be achieved with an oxygen flow rates of 10 to 15 liters per minute. Ideally, the NLM should not allow entrainment of air, but because of safety concern, one of the 2 exhalation ports is not provided with valve. That is an unbreather. The advantages, high oxygen supply rates are required. Desirable in cases where the breathing of CO2 would be detrimental, for example, after head injury. Best results will be achieved by adequate flow rates, such as that the receiver bag empties by no more than a third during inspiration and by best seal possible between the mask and the face. The advantages, it's a highest possible fraction inspired oxygen without intubation, suitable for spontaneous breathing patients with severe hypoxia. Disadvantage, it may be expensive, require tight seal, uncomfortable, interfere with eating and drinking, not suitable for long-term use. Malfunction can cause CO2 buildup and suffocation. We have the Venturi mask. It delivers fixed concentration of oxygen. The size of the constriction determines the final concentration of oxygen for a given gas flow. As forward flow of inspired gas increases, the lateral pressure adjacent of inspired oxygen, fractional inspired oxygen of 24, 28, 31, and 35, and 40, and 60%. Because of the high fresh gas flow rate, the exhaled gases are rapidly flushed from the mask via its holes. Therefore, there is no rebreathing and no increase in dead space. These masks are recommended when a fixed oxygen concentration is desired in patients whose ventilation is dependent on the hypoxic drive. This is the entrainment mask of the Venturi mask. That is how it looks like, and that is how it is. So the different Venturi mask comes in different colors, and every color presents a percentage of oxygen. So if you look at the blue, the white, the orange, the yellow, the red, and the green, or they have different types of different percentage of oxygen. When you come to advantages, fine control of fraction-inspired oxygen is at fixed flow, fixed, reliable, and precise of oxygen. High flow comes from the air, saving the oxygen cost, can be used for low oxygen also, and it helps in deciding whether the oxygen requirement is increasing or decreasing. Disadvantages is uncomfortable, it's expensive, cannot deliver high fraction-inspired oxygen. It can interfere with eating and drinking because it's a mask. So we look at the table above there. It talks about the flow rate, how much the nasal cannula gives, how much the transentracheal catheter gives, how much an oxygen mask gives, how much a reservoir gives, and how an unbreather gives, and also a Venturi mask. High flow nasal cannula delivers heated and humidified oxygen via special devices, e.g. the Vapotherm. The rate is up to 8 liters per minute in infants and up to 40 liters per minute in children and adults. In patients with respiratory distress failure, oxygen by humidified high flow nasal cannula may be better tolerated than by mask. That is the high flow nasal cannula, especially these we use it during the time of COVID. They were very common in COVID, though even now we are using because of most of our patients who have lung issues. High flow nasal cannula washes out carbon dioxide in an atomic dead space, creates positive nasopharyngeal pressure. The oxygen remains relatively constant because gas is generally warmed to that 7 degrees centigrade and completely humidified. Mucociliary functions remain good, and little discomfort is reported. That is our Nason, the high flow machine, which were very common during the COVID time. So I want to summarize in one thing. When you want to do a selection of a device, the following should be involved: the purpose, the patient, and the performance. The goal is to match the performance characteristics of the equipment to both the objectives of therapy, which I mean the purpose, and the patient's special needs. So one, the purpose is to improve the arterial hypoxemia. The second one is patient factors, which include the following: severity and the cause of hypoxia, patient age group, as I had earlier repeated, the degree of consciousness, the presence, the stability, and the mouth breathing versus nose breathing. As I had earlier repeated, and then we come back to the adult patient with COPD with acute or chronic hypoxia. The goal is to have an adequate arterial oxygenation without displacing ventilation. The adequate SpO2 of 85 to 92% is very good for the COPD. It's very bad when we see patients coming with COPD with an NRM, because we end up retaining a lot of CO2. We have low concentration of ALM Venturi mask of between 24 to 28 or low flow nasal cannula. So when you're having COPD, we need to give them very little oxygen just to help them to improve the adequate oxygen in the arterial blood. We have critical ill adult patient with moderate to severe hypoxia. The goal, we need to have more than 60 millimeters mercury, SpO2 of more than 90%. There can be receiver or high flow system of more than 60% of fractional inspired oxygen. Critically ill adult patient with mild to moderate hypoxemia, immediate post-operative phase, recovering from myocardial infarction, stability of fraction inspired is not critical. System with low to moderate fraction inspired oxygen, nasal cannula or simple mask can be of help to such a kind of a patient. So when we need to titrate oxygen with an SpO2, we have to monitor the patient slowly by slowly. When you come with the nasal plungs for oxygen from 1 to 5 liters, we need to come down to that kind of level and should have, for the infant, we should have between 45% to 60% of fractional inspired oxygen. For our infant and a child, between 44 to 60, depending on what the condition the patient has, depending with the need and the requirements of the patient. So you cannot just titrate immediately. You have to go slowly as you monitor the patient via the SpO2 and the arterial blood gases. So we had talked about the devices. The only thing that I would only say is that whenever if the nasocardial just give between 2 to 4 liters per minute and give you 28 to 36% of oxygen, even if you increase it to 6 liters, it does not increase more than what it is required to give. Be it nasal catheter, it's supposed to give between 35 to 40%. Even if you increase more than that, it will not give more than what is expected from it, because that is the much that it can give. Be it the face mask, when you give up to 5 to 6 liters, when you give at 8 liters, it will not increase the fractional inspired oxygen to that patient. Neither the partial breathing mask, neither the non-breathing mask, and even high flow nasal cannula deliver seated and humidified oxygen via special devices, and it can only do between the 8 liters in infants and 40 liters in adults or more, depending on the need. But high flow washes out carbon dioxide. We had talked about that, creates positive nasopharyngeal pressure. It remains relative calm, and it is warmed, so there's no need of modifying it. Because the mucociliary functions remains good and literal discomfort is literally repeated. That one I had talked about earlier. But the main key reason for here for us is about oxygen. It's an aerosol generating procedure. Ensure that you observe IPC protocols. Ensure that devices are checked regularly to prevent cross-infection. So how long should a patient remain with an oxygen nasopron? How long do the patient stay with a mask? How long does the patient remain with an NLM? And with the things that comes with the face and the cross-infection, we should observe the infection prevention protocols. Ensure that devices are recharged regularly. We need to stop oxygen wastage, which is expensive. We need to monitor patients closely with our pulse oximetry, our respiration, our pulse rates, with a pulse oximeter. You do our BGS, arterial blood gases. We need to win oxygen slowly, and we should not stop it abruptly. And if there is any alarm, we need to consult. We need to educate our patients on how to manage their oxygen, and even those that are on home oxygen therapy. How should they maintain their devices? How should they maintain their concentrators? By the time the patient goes home in oxygen, how far have you titrated that oxygen to the body requirements, so that the body can be able to adjust and to be able to breathe in? Thank you.
Thank you very much, Joanne, for a great presentation. I see there's some questions, and I think we have enough time to capture a couple of questions. So there's one question I saw on the chat. Yes. Just ask that. So how do we wean off oxygen in a neonate who was getting 2 liters per minute?
Use it slowly. If she was at 2 liters, how do you go to 1? You have to reduce slowly by either by arterial blood gases or the pulse oximetry. If she was in 2 liters, you go down by 0.5 liters per minute. Then observe within the 24 hours. How does that child breathe? Is there any deviation? Then you continue. So you have to monitor that child closely for over 24 hours, so that as you continue reducing, the body will be able to adjust and to be able to take up the oxygen as it's required, as the body requirements, because it's the body that requires that oxygen. How it breathes and be able to accommodate those lungs, it will be able.
All right. Good. There's another question now in terms of which oxygen mask can we use on premature newborns and how much oxygen? I guess how much liters per minute? Premature newborns. Should we be giving them oxygen?
We used to use mask, but there was a lot of damage with the mask because of the blindness. It caused a lot of blindness and havoc. These days we use the nasal cannulas or the nasoprone for the neonates. They should be the devices should be articulate for the age. If it's a neonate, let it be a neonate. If it's a bigger child, and if you're a bigger child, let it be, because you should have a device that is for that category of a child. If it's a neonate, let's have those small catheters for those neonates.
Okay,
and
good.
oxygen.
Yeah, there's another question in terms of oxygen saturation. Oxygen concentrators versus oxygen cylinders. What should people focus on, I guess, getting, or how good are oxygen concentrators? I think that's the word that's the oxygen concentrators.
Oxygen concentrators they may be expensive when you are buying them, but they are very economic when you have a patient of long-term oxygen at home. Because what they do is that they collect the air, they collect the air around us, and then it filters and cleans up, and then it delivers. But in terms of oxygen cylinders, you keep on refilling. And I think it's very expensive to just one cylinder. The small cylinder, the latest that I checked on, it was to refill it is about 6K. But 6K. So how long, if it's somebody who is on long-term oxygen therapy at home, how long is he going to take with that cylinder? So it's more economic to use an oxygen concentrator, because the only thing that you may be paying for is the power. It's only the power, but you'll be able to use it at home, and you can walk. There are some which are mobile. The ones that you can carry with the Landsack, especially for our students, because that is what we recommend for them. There are some that you can, for the elderly, we give them those ones that you can just move around from the area, depending on also on how much you can afford. Also, it's a cost effectiveness and how much you can be able to afford.
And I think just even like Cincinnati has asked a similar question. Do you get 100% of oxygen off the oxygen concentrators? And can you deliver like 15 liters per minute from a concentrator? Or what levels of oxygen are you able to deliver with the concentrator?
In terms of home oxygen delivery and home oxygen therapy at home, we discharge a patient, like we have so many lung respiratory patients or chest patients who are on oxygen at home. But by the time they are going home, it's a program that we have been going. And then the other thing that we must be lacking is maybe pulmonary rehabilitation, which could also be assisting, and which we are trying to see whether we can get more of people to be trained on terms of pulmonary rehabilitation. But when it comes to oxygen, concentrator cannot give 15 liters. Oxygen concentrator is only for home delivery, cannot give. The much it can give, it's up to 8. Though we have oxygen concentrators of 10 liters. But the max they can go is up to 10, 8, 10, but not really. But those are for people who are going for home oxygen therapy. And when we are taking the patient, we have to wean them from our medical oxygen, because this one is it's another machine. And when you are putting a patient on a concentrator, you have to wait in a new concentrator. You have to wean off the patient to a level that is able to maintain at that level. Then you can move him to that machine so that he can be able to the body to adjust to that different machine. Because initially the hospital oxygen is very different from what happens in the machine. So if you come into a machine, which the patient I put, and then the patient desaturates, then that machine is not, we cannot use it for that patient, because here we are here to help the patient to breathe and to make the breath comfortable and to breathe easy.
Okay. Actually, that's a good point you brought in because I've seen a lot of emergency departments in the country having concentrators for emergency, using concentrators in the emergency department. I think the point you just mentioned makes a good point, is we probably should be advocating for piped medical oxygen in the hospital and reserve concentrators for home use. What do you think?
For how for concentrators for the small hospitals is good for the small hospitals, especially for more. But now, concentrators is them good for the patients who are going home. Because if it's a patient who really needs 15 liters or 15 liters, we'll not be able to give from a concentrator. Like when I'm doing a lung function, because I do spirometry and the lung function to patients even on oxygen, I do them with a concentrator, because I have a concentrator wherever I am in my station. Because where I am for now, I'm in my own, in my workstation, and I have concentrators for the patient, especially who are coming for lung function. So in the lung health, and I wanted to say very well, in most of our lung patients, they really don't really need much of the lot of oxygen. But in terms of oxygen in patients with heart, you may get a patient with a heart condition, and the saturation is 100%, but the heart rate is above 120. You need to take care of the heart so that it doesn't have an infarct, so that it cannot get an overload. So sometimes there's a lot of differences in how we are managing our oxygen, especially from the A&E. Because patients in lung health really need very little oxygen, because most of the oxygen is really, most of the cleaning and the exit of gases is done in the alveoli. And when you start pumping and it's a diseased lung, it's not be able, and that's why you get up that you get a lot of COPD patients detaining about CO2, and when you put a vent, they don't come out of a vent. They don't come. So we need to help on how do we get out the pump out the CO2 if we manage to put. And that's why in our setup, we have even Venturi masks. We have different colors they come. So we have the Venturi masks that we usually use them, especially it's very rare when we have a patient landing into medical CCU just because of retention of CO2 retention. Because when we do the Venturi masks, we're able to reduce the oxygen as per the condition of the patient and how she is progressing, because you cannot stop it drastically. When you're winning oxygen, don't stop it drastically. You need to reduce 0.5, 0.5 as the body adjusts to that kind of, because that body has to adjust to the level of the oxygen that you to be able to do.
I think there is a lot of concerns about the toxicity of oxygen. I see Catherine has put in there that oxygen should be monitored, toxic use wrongly causes blindness, and also consider CPAP. And then there's an attendee who's asking what are the dangers of higher concentration of oxygen in neonates. Maybe I think just overall, just recapping, like what are the dangers of too much oxygen?
There is a lot of toxicity in oxygen in small children because we were using masks a long time ago. They caused a lot of blindness. You become so dependent. If you are not weaned off in the light way, you become an oxygen dependent. Then there are other complications that happen in oxygen in terms of oxygen. Apart from the blindness, that is times that it brings the times that you get a headache, the others who get a headache, something of the sort. Either it goes down as it's too much, especially when in a COPD, when you give so much of oxygen, they still have a headache. But when you give to the right level, they never get to that headache. So it depends on at what level that patient is. But in small children, especially the neonates, don't give you the mask. Don't give oxygen with the mask. The studies were done some years ago, and they showed most of the children, the neonates got bright. There was a lot of brightness. There was an issue that happened then, many years ago. Some studies that were done,
actually,
I can't remember when.
Okay. Yeah. Thank you very much, John. I think, yes, oxygen. I mean, there are a few other things that if you look at current stroke and heart attack guidelines, even they recommend keeping your oxygen saturations just at 90%. And if your patient is saturating at 90%, you don't need to give more oxygen. And all of this is because oxygen is a vasoconstrictor. And that's why, like in stroke and heart attacks, because of the vasoconstrictive effects of oxygen, it's limited use in such settings to only patients who have saturations below 90%. The other part of it, of course, is, and there was that discussion around the oxygen dissociation curve. Again, too much oxygen then leads to the formation of oxygen radicals, which then are toxic to your tissues and lead to a lot of damage, which is what even Joanne is talking about in terms of causing the blindness that happened in many neonates. But yes, that effect is there. Oxygen toxicity can cause subcutaneous emphysema. I'm not sure about that one. I don't know, Joanne, any understanding around? I don't think toxicity can cause subcutaneous emphysema
I don't
because
think.
that's usually a traumatic. Yes, that's usually a
Uh,
traumatic issue.
the other thing I would like
Um,
to comment, sorry, the doctor, the other,
yes,
that
go ahead, go
whenever
ahead,
you
go
find a
ahead.
patient, yeah, the time that you get a patient that saturation is at 85, don't give 15 liters. Just give very little, just to make it at 90. A patient with 70% of oxygen saturation when you have done an SpO2, and then you look at the clinical aspect, because the clinical presentation of that patient gives you the picture of that kind of a patient. And like in terms of this, the traumas, you can give a lot of oxygen. But when it comes to the medical part of it, some of these patients don't need an unbreather. They need a very little oxygen to make it at allowed 89, 90, at 292. They're okay. They're okay. So we should always bear in mind how much saturation do you have in this patient and how much oxygen should you give to that patient, and what the presentation of that patient.
Actually, that's a very good point. And I think we also need to emphasize the same discussion you brought up in terms of oxygen is a drug. Okay, if we look at it from a healthcare perspective,
Yes.
there's a point where we give patients, even fluids, when you're giving patients fluids, you don't just say run fluids like a tap
Yes.
until Christmas comes, I guess. There's always a control in terms of how much fluids you should give. And like with any other drug, even dosages, you can't say give a patient ceftriaxone, just run it 1 gram every minute until kingdom comes. So in the same concept, you should always consider oxygen as a drug. And there are the targets, which is what Joanne is highlighting. There are the targets of how much oxygen, what saturation you should be targeting. And again, above 90, 92% is good. And maintain it there. So giving oxygen without a pulse oximeter, for example, if you're not able to monitor patient saturations, is pretty much working in the darkness, essentially, or flying blind and not being able to tell how much oxygen and where the oxygen levels are. So always the two things that definitely have to go in with giving oxygen is, of course, you must have a pulse oximeter to be able to monitor. And again, you should be able to titrate the oxygen based on the patient's requirements versus just blindly saying, give so much oxygen. Joanne, there's a question around sickle cell disease. What is the SpO2 target?
Being a adult or a child.
Yeah, the
Is it an
sickle cell
adult or a child?
crisis.
Because a child, you need to make it around 90. 90,
Okay.
92 then. The target is
Yeah.
about 92. The target is about 92.
Yeah.
Literally, and
yeah,
then
from my
also
clinical
the other
experience.
thing, the issues of
Okay.
blood, because of anemia,
Yes.
we need to boost our blood, because most of the sickle cell patients usually have a low blood, a hemogram.
Yes.
We need to boost the hemogram. We need to collect the hemoglobin to make sure that we have a good collection of oxygen going through to the blood cells, so that you can be able to maintain it at around 90, 82.
So that last point is very good. Yes. The hemoglobin, remember, you need the hemoglobin to move your blood, to move your oxygen. So
Yes.
as much as you're trying to give oxygen, also factor in correcting the patient's hemoglobin to be able to allow the movement of the oxygen. And yeah, so saturation of 92% for most patients, actually.
Mm.
That's more or less the recommended. If your sickle cell patient is hypoxic, then you need to consider acute lung crisis or acute chest, which is where they start having a bit of infections around the lungs. And that's a patient who needs definitely to be admitted and seen by the relevant specialist, especially if you're seeing them from the emergency department. Ideally, sickle cell patients should not be hypoxic. If they're hypoxic, that means you are probably having an acute chest crisis and you need that patient admitted. There's another question, I think, for pediatric patients. I think Joan has discussed a lot of this in terms of ideal. Okay, maybe Joan, maybe you can comment. Carol, what is the most ideal oxygen adjunct for pediatric patients coming to A&E? I'm guessing that she's asking about the device. So do we give them, for pediatrics, do we put them on a face mask? Do we put them on nasal prongs? Which devices have you found most comfortable with pediatrics?
The most comfortable is a nasoplon, but what guides us in terms of giving oxygen is the presentation of that person, that patient. How much oxygen does he require? What did the presentation of that patient come with? And then as we go down, then we can go down to the nasoplon. But in most of the cases, I've not seen children needing so much of the oxygen on oxygen, maybe from the acute phase, and then we need to titrate it slowly by slowly. The only problem that we have been having, we get on forgetting that the child came from the A&E with 10 liters, but we forget that after 24 hours as the progress the child, we don't come to titrate it. And how should we titrate the oxygen? We need to get a little bit, the child to be out of our oxygen either 1 minute, take the saturations, take saturation, he is on oxygen, and when he is on oxygen, then you'll be able to titrate that child, the oxygen. You don't just do it abruptly like that. You have to know how much far can she do, how much is he desaturating, and then you can be able to balance that oxygen, either by a pulse oximetry, either by arterial blood gases, but arterial blood gases may be more expensive because of the process that is given, but you can do very well with an accurate pulse oximeter, because sometimes you find in pediatrics, we are using an adult pulse oximeter, which will always give you a delayed results. Let's have the right pulse oximeter for children, the pediatrics ones that are of the same size. Can you hear me?
Yeah, thank you very much. And I think, yes, I think that's very correct in terms of using the appropriate device for the appropriate age group, and of course, monitoring the patient closely. I see David Aliba is asking, does supplemental oxygen add any value to patients with a panic attack or anxiety?
Dr. just help me that one, nothing. I
Oh,
haven't seen it.
Oxygen, there are two things oxygen does not cure. Oxygen does not cure shortness of breath. Oxygen does not cure tachypnea. Oxygen does not cure anxiety or panic disorders. Oxygen just cures patients who have hypoxemia. That's it. So do not use oxygen. Patient comes in shortness of breath, for example. If they're saturating at 100%, remember, again, we also forget that we have 21% oxygen in air. So if a patient is coming, yes, they're still getting oxygen. It's 21%. So they should be breathing, they only breathing 21% and are saturating at 100%, or even just let's say even above 92%. So the question is, when you're giving oxygen, where do you want them to go? How much? I mean, you're at 100%. How further up can you go? If you're all your blood cells already saturated with oxygen, giving extra oxygen is just essentially more or less causing toxicity for the patient. It's a wastage of the oxygen. And yes, as discussed here, there's potentially harm that you're causing the patient. So do not give oxygen to a patient who is not hypoxic. The only exception to this rule is your carbon monoxide patient, where your patient will probably have falsely elevated saturations on the pulse oximeter. And so your carbon monoxide patient is only carbon monoxide poisoning patient is only one who needs 100% oxygen. Most other people, you need to titrate to just get them above 92% as Joan has provided. It's a ventilation. Joanne, are you keen on discussing? There's a question from Salome about best mode of ventilation on the ventilator settings for ARDS. Do you want to comment or do you want me to comment?
Comment, Daktari.
Okay.
Comment.
Salome, we will definitely, I think we have some videos on ventilation in our YouTube channel, but I think the simplest answer to your question is ventilators are fantastic devices. You can ventilate a patient with any mode whatsoever, as long as you know what you're doing. Okay? So there is no, if you ever hear someone saying one mode is better than the other, that's a lie. It's a machine, and as long as you understand how each mode works, you can then vary based on what you want, which one works best for your patient. So similarly, the way you titrate oxygen to your patient is the same way you'll adjust your ventilators. So yeah, so do not there's no one best mode. It's the mode A, the mode you're most comfortable with, and the mode that your patient will be more comfortable with as you because sometimes you put one mode, it's not really working for your patient, then you switch to the other mode. Yes. All right. Patients, everyone, saturations 92%. That's it. Doesn't matter the underlying, and apart from your COPD, probably normally we target around 80. Joanne, what's the target? Is it 85 to 88 for COPD patients, oxygen?
85 to 88.
85 to 88%, yes. Last question, I think, to end this, a very interesting question from Sinet. Does oxygen expire?
It doesn't expire.
No. All right. I don't think it expires. And yes, but again, always if you have not used like a tank for a long time, always make sure that the tank has been serviced by biomedical people, just to avoid any injuries or anything. All right, Joanne, any last comments before we close the session?
Especially the patients who are using home oxygen therapy, especially the oxygen concentrators, those machines should be changed, especially the filters. People have to understand that the filters, they get blocked and the machine may be stop working. And those are the things that I keep on meeting every day. So they need to be cleaned. Wherever you buy a machine, you need to get somebody to can be able to help you to change the filters. The other thing is that those machines should, especially concentrators at home, and even when you in any hospital, a patient is supposed to have oxygen concentrator. The concentrator should not be put next to the wall. It should be away from the wall, so that we have a way on how to get the air. Can you hear me?
Okay.
Yes.
Yes. No, trying to understand.
Away from the wall. It should be where it can be able to collect air. Two, the other thing that that I also deal with this is about there are patients who cannot be able, the patients who have the kyphosis, especially our youth or the young children or the young. There are some of them who have gone home with BiPAP. And they go home with the BiPAP and we're able to do. Me, I'm not a critical care nurse. I'm just a respiratory nurse. I can only do a home device like a BiPAP. They go home with a BiPAP at home. And then they manage where the oxygen and they leave. And that is okay.
Thank you very much, Joanne. It's been an exciting discussion, and I see there are a lot of people who have very good questions. And thank you for joining us this evening on our monthly talks. And thank you everyone who's joined in this evening. We have an exciting series scheduled for next month. You'll see us advertising. We have a whole month of pediatric webinars starting, I think, next week, Thursday. And the exciting topics that will be coming up there. So really looking forward to that.